I'm John Strum, and this is Real Talk MS. It's January 7th, and we have a lot to talk about. As most of you probably already know, there are genetic risks associated with MS. There are demographic risks of experiencing a more severe disease course. There are also environmental, behavioral, and lifestyle risks that will increase the chance that someone will be diagnosed with MS. Joining me today to discuss MS risk factors are Dr. Jared Bruce and Dr. Amanda Bruce. Dr. Jared Bruce is a neuropsychologist and the director of psychiatric research at the University of Missouri, Kansas City School of Medicine. And Dr. Amanda Bruce is a clinical psychologist and an assistant professor in the Department of Behavioral Pediatrics at KU Medical Center. But before we get to my conversation with Drs. Jared and Amanda Bruce, there are a few other things that you should know about. 2025 brings with it a lot of questions about what U.S. healthcare policy is going to look like. But today we can celebrate the fact that beginning last week, the annual out-of-pocket cost of prescription medications for the 250,000 people living with MS who are on Medicare is now capped at $2,000. According to the Department of Health and Human Services, that translates into a savings of about $1,500 a year for someone who depends on high-priced medication, like any of the MS disease-modifying therapies. This good news is a result of the Inflation Reduction Act that was signed into law in 2022, with this particular provision becoming effective in 2025. While the Inflation Reduction Act covers a lot of ground, it's also the largest and most consequential healthcare bill passed by Congress since the Affordable Care Act, delivering several significant healthcare benefits without raising taxes on small businesses or on families earning $400,000 a year or less. MS activists played a major role in seeing this legislation become law. From the day when Stephanie Stern, the Vice President of Advocacy for the National MS Society, testified before the Senate Finance Committee and shared her own family's struggles to afford disease-modifying medication for Stephanie's mom, who's living with MS, to the thousands of emails and texts that MS activists across the country sent to their senators and representatives in Congress, this was a team effort that led to a big win. As 2025 gets underway, I have little doubt that we'll be presented with new opportunities to advocate on behalf of the nearly 1 million families affected by MS in the United States. You can be sure we'll be talking about those advocacy opportunities as they arise. IO Therapeutics has shared study results showing that their investigational compound called IRX-4204 was effective in reversing demyelination and functionally restoring movement in the paralyzed legs of mice with the mouse model of MS. IRX-4204 selectively activates a receptor called the retinoid X receptor, which is involved in activating microglia. These are the cells in the brain which, among other things, clear debris from other damaged cells. The research team found that IRX-4204 not only blocked the progressive loss of mobility that the mice were experiencing, but also reversed the impairments to movement that had already developed. As a result, the mice experienced improvement in their gait. The scientists were able to measure remyelination as well as reduced inflammation in the central nervous system. Remyelination carries with it the promise of restored function. These study results represent evidence of that restored function. And while there are huge differences between a mouse brain and a human brain, this is a significant step forward in identifying therapies that can effectively treat demyelination, not only in MS, but in other neurological conditions in which demyelination and microglial inflammation occur. IO Therapeutics is planning to develop IRX-4204 as a potential therapy for multiple neurological disorders. And if you'd like to review the details of this study, you'll find a link in today's show notes. In previous episodes of the podcast, we've talked about the relationship between MS and comorbidities, or other chronic health conditions that someone with MS might also develop. And those conversations about comorbidities have focused on how having another chronic health condition might impact your MS treatment, or how having MS can sometimes make it more difficult to recognize or diagnose a comorbidity. Comorbidities have been associated with worse patient outcomes, including delaying an MS diagnosis, experiencing greater disability at the time of diagnosis, faster disability progression, reduced quality of life, more relapses, and increased mortality. But there hasn't been much research done in determining how specific comorbidities affect specific outcomes, like when someone starts their disease-modifying therapy, or disease progression, or mortality. Understanding how a coexisting health condition will impact disease progression could allow a neurologist to better tailor an individual's MS treatment plan, leading to a better outcome for that patient. So a Canadian research team conducted a rapid review of 100 studies from Europe, North America, and the Middle East that were published between 2002 and 2023. These were studies that examined the effects of other health conditions on starting MS disease-modifying therapy, disease progression, and mortality. The studies examined 88 different chronic health conditions. 87 of the 100 studies focused on disability progression, and 11 studies focused on mortality. The researchers found that depression, epilepsy, restless leg syndrome, narrowing of arteries, and psychotic disorders are most consistently associated with worse disability in people with MS. Anxiety, bipolar disorder, chronic lung disease, high cholesterol, coronary artery disease, and obstructive sleep apnea are associated with a decreased likelihood of starting an MS treatment, while depression is associated with an increased likelihood of starting an MS treatment. Depression, diabetes, epilepsy, and cancer are consistently linked to an increased mortality risk in people with MS, and some relationships between a specific condition and an MS outcome, such as the relationship between anxiety and disability, showed conflicting results, with studies showing increased or decreased disability, or no association at all. If you'd like to review the details of this study and note the relationships between a specific comorbidity and a specific MS outcome, you'll find a link in today's show notes. And if you'd like to review a version of this study in easy-to-understand plain English, you'll also find a link to my friend Sharon Roman's excellent plain English explanation of this study. All the current MS disease-modifying therapies are considered to be either high efficacy or moderate efficacy. The high-efficacy DMTs are the newer drugs that have been shown to be better at reducing disease activity and slowing disease progression. These drugs also carry greater safety risks, and they're more expensive. Moderate efficacy DMTs tend to be safer, but less effective at slowing MS. A research team in Texas compared the effectiveness of high-efficacy DMTs with moderate-efficacy DMTs among adults in the United States, and they also wanted to determine whether there was any difference in treatment response between men and women. The researchers analyzed data from the U.S. Meritive MarketScan Commercials Claims and Encounters dataset. This is a database which contains de-identified insurance claim information collected from inpatient, outpatient, and community pharmacy settings. Most patients in this database are insured through large companies, governments, or nonprofit organizations. The researchers examined this information for 10,003 adults who were diagnosed with MS between 2015 and 2019 and had been prescribed at least one disease-modifying therapy after being diagnosed. Each of these adults was followed until they switched to another DMT, fell out of the database, or the study ended. Among these 10,003 individuals, 77.1% started treatment with a moderate efficacy DMT, which included Copaxone and its generics, and Tecfidera and its generics. The remaining 22.9% began treatment with a high-efficacy DMT, including Ocrevus, Lemtrada, and Tysabri. The patients who started on a high-efficacy DMT were significantly older and had more severe MS than those who started on a moderate efficacy DMT, and more men were started on a high-efficacy DMT than women. DMT effectiveness was measured by the average number of relapses per year in each patient group, and the results of this analysis showed the average annual relapse rate was significantly lower for high-efficacy DMT users than moderate-efficacy DMT users, and that's consistent with other research results. However, this analysis also revealed that only men had a significantly lower risk of relapse, a 26% lower risk of relapse, when they started with a high-efficacy DMT. For women, the average annual relapse rate was the same regardless of whether they started with a high-efficacy DMT or a moderate-efficacy DMT. As we see the treatment of MS continuing to move toward treatment plans that are personalized for an individual, this study points out how sex-specific variation in treatment effectiveness needs to be further researched and then applied to those personalized treatment plans. If you'd like to review the details of this study, you'll find a link in today's show notes. By now, I'm sure most everyone has taken ChatGPT for a test drive. Some of you may already be using it regularly as part of your work or studies. ChatGPT is a type of artificial intelligence called a large language model, or LLM. And most of us use large language models like ChatGPT to answer questions based upon their ability to retrieve information. But now a research team at University College London has published results of a study showing that large language models can predict the results of proposed neuroscience studies more accurately than human neuroscience experts, making these LLMs potentially powerful tools for accelerating research. Now, in the first phase of this study, the research team developed a tool capable of evaluating how well large language models can predict neuroscience results. They called this tool BrainBench, and BrainBench consists of a large number of pairs of actual neuroscience abstracts. These are the published summaries of neuroscience studies. In each pair, one version is the real study abstract that briefly describes the background of the research, the methods used, and the study results. In the other version, the background and methods are the same, but the results have been modified by experts in the relevant neuroscience field to a plausible but incorrect outcome. The researchers tested 15 different general-purpose LLMs and 171 human neuroscience experts who had all been screened to confirm their expertise. The research team wanted to see whether the AI or the human expert could correctly determine which of the paired abstracts was the real one with the actual study results. All of the LLMs outperformed the humans, with the LLMs averaging 81% accuracy and the human experts averaging 63% accuracy. In the next phase of this study, the researchers adapted an existing open-source LLM called Mistral by training it specifically on neuroscience literature. This new LLM, which they called BrainGPT, was even better at predicting which study results were the actual study results with 86% accuracy. The lead author of the study, Professor Ken Luo, said, and I'm quoting, "We envision a future where researchers can input their proposed experiment designs and anticipated findings, with AI offering predictions on the likelihood of various outcomes. This would enable faster iteration and more informed decision-making in experiment design." End quote. Now, this study wasn't MS specific, but since they chose to use neuroscience as their test case, I thought it was worth sharing with you. As I've said before, AI will have a profound impact on every aspect of healthcare, from the lab to the clinic. This study opens a door to using large language models to design better clinical trials, and that means better outcomes that lead to new treatments and cures faster. If you'd like to review the details of this study, you'll find a link in today's show notes. You don't need artificial intelligence to understand that there are risk factors associated with developing MS. There are genetic risks associated with MS. There are demographic risks of experiencing a more severe disease course. There are also behavioral and lifestyle risks that will increase the chance that someone will be diagnosed with MS. Joining me in a moment to discuss these MS risk factors and how they might be mitigated are Doctors Jared and Amanda Bruce. Scientists have studied a variety of possible causes and risk factors for multiple sclerosis, and research shows that it's likely a mix of genes, something in your environment, lifestyle factors, and behavioral lifestyle risks. Joining me to discuss risk factors that could increase the chance of someone developing MS are Dr. Jared Bruce and Dr. Amanda Bruce. Dr. Jared Bruce is a neuropsychologist with research interests in sports concussion, multiple sclerosis, and the prevention and treatment of cognitive neuropsychiatric disorders, among others. He's a professor and director of psychiatric research at the University of Missouri Kansas City School of Medicine. Dr. Amanda Bruce is a clinical psychologist with a research interest in the clinical phenotypes and neural foundations of health-related decisions, including treatment adherence choices, physical activity, and food choices. She's an assistant professor at KU Medical Center in the Department of Behavioral Pediatrics. Dr. Bruce and Dr. Bruce, welcome to the podcast.
Thanks for having us here.
We're excited to be here. Thank you.
Let's start by talking about behavioral and lifestyle risks that are related to MS. I have a question for both of you because you both recently co-authored a study on modifying diet and exercise in MS, as well as protocols for a telehealth weight loss intervention for adults with obesity and multiple sclerosis. Could you share more about that research and your findings?
Yeah, happy to do so. Really, we started having an interest in the brain and obesity about 15 years ago. We were interested in how carrying excess weight might be associated with different brain changes. In particular, we're interested in how different types of weight loss might change the brain. So how do changes in the gut affect changes in the brain? And around this time, there was also an increased interest in the association between obesity and multiple sclerosis. And I should say an increase in obesity that's happened over the last 60 years that is really quite astounding. Especially in the United States, we've seen a tripling of obesity, such that about 70% of people in the United States are either overweight or obese currently. And we've also seen that increase in obesity in people with MS. And so we were interested in trying to better understand that relationship. Around that time, especially over the last 10 years or so, there's also been an increased understanding that people who have obesity have an increased risk of developing MS. And both carrying excess weight and having MS are autoimmune processes. So obesity affects the immune system. Obviously, MS is an autoimmune disease. And so trying to better understand that relationship has been one of our cardinal goals.
One of the questions that we had was for adults who are carrying excess weight and who have MS, are they able to lose weight? Is that something that is even feasible? And if they do lose weight, how does that affect their lives? Do we see any positive effect of that weight loss?
Yeah. And so one of the things we wanted to do was, like Amanda said, see if people could lose weight if they have MS. It turns out that most of the weight loss research that's been done over the last 50 years or so, they'll exclude people who have MS. They'll exclude people who have any kind of neurologic disorder. They want a sort of more perfect population to study. And there are very few studies out there that have actually examined whether behavioral intervention can help people with MS lose weight. And so that's one of the things we wanted to see. And so we did a randomized controlled trial that was funded by the National MS Society. We had lots of great participants with MS who volunteered their time to be part of this study. And we randomly assigned people to either a weight loss condition or a control condition. And the weight loss condition included a lot of different components. We had technology. So we had people use apps to track their caloric intake. They had a Wi-Fi scale so they could weigh themselves on a regular basis. They also had weekly coaching sessions in a group, and then monthly individual sessions with a weight loss coach. And that happened over a period of 6 months. And then what we found was that indeed we could help people with MS lose weight. We had really good findings such that, was it 65%? Mm-hmm. 65% of people lost clinically significant amount of weight. And on average, people in the weight loss condition lost about 8.5% of their body weight.
And people enjoyed it too. In terms of satisfaction, we saw really high satisfaction scores. People enjoyed the group sessions that were facilitated by a weight loss coach. They enjoyed the individual sessions they had. A lot of people developed quite a bit of camaraderie in those groups. I mean, there was a good connection that was built in addition to these outcomes. And not only could people lose weight, but their quality of life improved. When we, asked about quality of life at the beginning of the study and then at the end of the study, their quality of life was significantly better after the intervention.
And that's one of the things we wanted to see. We know that obesity and MS have a lot of overlapping symptoms. So, for example, people who have obesity frequently have mobility problems. Well, so do people with MS. And people with obesity frequently have mood symptoms, as do people with MS. And so one of the nice findings from the study was that not only could we help people lose weight, but we also help people with MS in terms of their mobility. When they lost weight, their mobility improved. When they lost weight, they reported less fatigue. They reported higher quality of life. So we were very encouraged that the intervention not only helped people lose weight, but also helped with some of their common MS symptoms.
The to be continued part of this, though, is, does this impact disease trajectory, right? Like for these folks who lost weight, will this mean fewer exacerbations? Will this mean fewer lesions? We don't know. And, we would have loved to follow these people further, but of course that's expensive, right? That requires a lot of funding.
It will require a much bigger research study to understand whether weight loss slows disease progression, even though we are encouraged that we can help people lose weight and that it can help with some common MS symptoms.
We've been talking about adults with MS. Dr. Amanda, how does body weight, particularly obesity in early childhood and adolescence, influence the risk of developing MS?
It's a great question. And I do think it's a question that is not fully understood yet. But carrying excess weight early in life does raise your risk of developing MS. But that's not something that will set you on a course that you cannot deviate from. So, losing weight then can, we think, somewhat decreased risk of developing MS. But like I said, we don't fully understand this picture yet.
Yeah, and I think we really do need more research to see whether or not losing weight would have that impact. The gold standard for understanding causation is a clinical trial. And so there's a lot of research out there looking at associations between weight and disease and things of that nature. But if you really want to know whether a weight loss intervention changes or prevents disease from occurring, you need to randomize people to different conditions and do a clinical trial. And that work hasn't been funded to this point.
Dr. Jared, are there circumstances where someone can experience obesity while living with MS and still be considered healthy?
So that's a difficult question because it's hard to know what we mean by healthy. I mean, healthy is a word that means different things to different people. But what I can say is that there are different types of excess weight, and some of them are better than others. So, for example, we know that where you carry your weight matters in terms of your health, and that there's research to show that if you carry it mostly in your sort of upper torso and midsection, the sort of apple shape, that's associated with worse health outcomes than if you carry it in sort of your hips and lower part of your body, sort of the pear shape. That tends to not have as many negative health outcomes. Similarly, it matters, whether you have some common obesity-related health conditions. So if you have excess weight and you also have poorly regulated blood sugars, say diabetes, or if you have high blood pressure, if you have high cholesterol, if you have sleep apnea, all these conditions associated or can be associated with obesity, then that suggests that it's very important for you to try to get that weight under control, and perhaps more important than if you don't have those comorbid conditions.
Research shows that smokers have an increased risk of developing MS, and in fact, both active and secondhand smoking have been identified as environmental risk factors for developing multiple sclerosis. Dr. Amanda, what's the current understanding of the link between smoking and the risk of developing or worsening MS?
So no surprise here, smoking is bad, and it's bad in a variety of ways. So some evidence shows that smoking can make a person up to 50% more likely to develop MS compared to people who don't smoke. And for those people who have been diagnosed with MS, smoking can make the symptoms worse. It can speed up the disease trajectory and, increase how fast you become disabled. It can mean more lesions, bigger lesions, and more relapses. So bottom line is smoking is very bad.
Yeah, and if you are a smoker and if you have MS, it would be wise for you to talk with your doctor about ways to help you quit. There are effective means for helping people quit smoking, both medically and via counseling and coaching. They would encourage you to give a try because it would be really good for your health in the long run.
Let's switch gears from lifestyle-related risks to demographic and genetic-related risks that are related to MS. Dr. Amanda, are there differences in MS risk between racial and ethnic populations?
The quote-unquote experts used to believe that MS mostly affected white people, especially those of kind of European ancestry. But more recent realization and research indicates that, Black people, Hispanic, Latinx folks, more people in those groups have MS than previously thought. And unfortunately, Black individuals may face a faster progression, a more aggressive progression of MS, and greater disability levels. We also know that Hispanic and Latinx individuals tend to be diagnosed at much younger age, have earlier onset of symptoms, and then have mobility issues, optic neuritis, and overall more severe MS.
I'm curious, how much of the elevated risk, or I should say, not so much the elevated risk, but the disease course that you just described, how much of that is driven by social determinants of health?
Fantastic question and right on point, and I think a lot, unfortunately.
And I think that's the reason why for so many years people thought it was a white person disease, because people from underserved communities weren't getting diagnosed and people weren't giving them the appropriate treatment. So fortunately, that's something that's come out more. And I think that now that there's increased awareness, hopefully that people from underserved communities will get better care.
I think that the healthcare disparities, that movement and awareness of that is going to help, I think, in the field of MS and treatment. And hopefully this greater awareness will lead to better treatment for these folks.
Dr. Jared, if someone has MS in their family, maybe their grandmother and an aunt, or grandmother and their mother both have MS, are there steps that they can take, lifestyle changes they can make to help prevent MS?
Well, I think there are lifestyle changes we can all make to improve our health. And the kinds of recommendations I'd make for a person who is concerned about that would be the kinds of recommendations I would make to many of the different patients that I have who have a lot of different neurologic conditions. And so those would be things like eat lots of fruits and vegetables, eat healthy, maintain a healthy weight, avoid cigarettes and excess alcohol, get good sleep. If you do start to have some symptoms that are concerning to you, maybe some visual changes, some numbness or tingling, go to your doctor, and go to your doctor promptly, because early treatment of MS is very beneficial. And then make sure you work with your doctor to have good treatment adherence for the treatment plan you come up with together, because treatment adherence also is very important, especially in the early course of the disease, suggesting that the disease may not progress as quickly if you catch it earlier. And then the other thing I would say to this person is that just because your mom has MS, even if your grandmother has MS, that doesn't necessarily mean you're going to get MS. It's not an autosomal dominant disorder. There isn't one gene that's passed down from grandma to mom to you. Many genes are associated with MS. There is no single genetic determinant that says you're going to get it just because your parents had it.
Well, Dr. Jared Bruce and Dr. Amanda Bruce, thank you for all you do to improve the quality of life for people who are living with MS. And thanks so much for talking with me today.
Thank you, John.
Thanks so much for having us.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/384. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.